Thank you, Marisol. Give me one moment and I'll share my screen so I can begin our PowerPoint presentation. As Marisol mentioned, my name is Kenneth Parmenter. I go by Kenny. And I want to reiterate, if at any point during this presentation you have questions or comments or things that you'd like to add, please, I'd welcome you to unmute yourself or put it in the chat box. Also, if I'm speaking too fast, please let me know. I've got a lot of material I'd like to cover today and just an hour to be with you. And so we'll kick right off. So what are we here to learn today? We're going to go over why we're here, what do we do at Vecinos Farmworker Health Program, and why I'm presenting to you today. What is our purpose and the concept of mental health for migrant farm workers based on the beliefs and best practices that I've found. I'll also present some obstacles and difficulties to starting an integrated healthcare, especially during times of COVID, and where to get information and how to make it more accessible to the migrant farm worker population and seasonal farm workers as well. Before we really get going on the material, I'd like to invite everybody to take a moment to settle in. So whether you're in your seat or standing, try to get yourself situated, go ahead and shut your office door, put your cell phone on silent, put your cat on the floor, and start to notice where you're connected to the ground or the chair or the floor below you, whether it's in your seat bones or your back as it touches or your feet all the way grounded to the floor. I want you to begin to notice your breathing without changing anything. Just notice as you breathe in either through your mouth or your nose, if you're breathing into your chest or your belly. Now take a moment and put your hand on your belly and take a deep inhale through your nose. Slowly exhale through your mouth with your lips slightly pursed together so the air comes out slowly. Go ahead and do that one more time on your own. If nothing less, that helps me get myself ready to give a presentation. And hopefully it allows you to settle in and be present in this space as we have a lot of other things going on outside of this conference, I'm sure. So, who is Vecinos? Vecinos started as a nonprofit organization as part of the Jackson County Public Health Department in 2001. Jackson County is located in western North Carolina. I'll show you a map here in a moment. In 2004, we were officially incorporated as a nonprofit, and we serve the Farmworker Health Program through the North Carolina Farmworker Health Program. It was one of our granting agencies. At this time, we developed and built a mobile clinic that was donated from the Rotary Club and helped us serve the surrounding Western Carolina area, which is a remote part of the state. And I'll show you that in just a moment. In 2013, we based our administrative offices in Western Carolina University's campus. We have collaborated with the Harris Regional Hospital, our local hospital, to include and utilize their clinic space, which is part of the Western campus. In 2017, we expanded to the 8 Western counties. And in 2019, I came on board and helped develop an integrated behavioral health program. We received additional funding to support this program and pay staff to be on board. Our executive director and our board of directors began efforts to create a new mobile clinic as our services have grown. We wanted to be able to serve more individuals. And then in 2020, we responded to the COVID pandemic and began telehealth. We incorporated our new mobile clinic, and we incorporated more telehealth or COVID services to provide and serve the farm workers in that aspect. I think there's one more part on this slide. Oops, going back. So Vecinos currently has 6 full-time providers, including 3 outreach workers, 1 coordinator, 1 clinic manager. We employ contract workers, whether they're RNs or FNMPs, doctors, social workers with a licensed clinical social work degree. We partner closely with Western Carolina University to incorporate interns and volunteers as translators and interns in the nursing program, as well as interns in our social work or through the BSW or MSW program. In 2020, our numbers looked at, we had 420 medical encounters, 151 behavioral health encounters, including 39 patients, and a total of 1,438 patient encounters. These numbers aren't quite where we wanted them to be, partially due to shifting our focus to best serve farm workers and their families during the COVID pandemic. So what area are we talking about here? So we are looking at Western North Carolina. This is a map of North Carolina as a whole. Over here in the red circled regions, these are the counties that we serve. And it's pretty, if you've heard of Asheville, North Carolina, we serve pretty much everything west of Asheville, with a slight one farm in Buncombe County, which is where Asheville is located, and then moving all the way west to Cherokee County, including one farm in Raven Gap, Georgia as well. We serve a mix of H2A migrant seasonal farm workers. We provide free services to our population. We have 3 bilingual therapists in the Western North Carolina area. So looking at anything west of Asheville, there are only 3 licensed clinical social workers able to do the behavioral health, mental health work that we do. And this is a high needs area. Our HPSA scores, the health provider service area, is between 15 and 20. So that's a pretty severe deficit for the mental health needs of this population in our location. And one of the reasons that we began this program was because we were noticing a lack of resources and availability of mental health services, especially provided in Spanish. In starting this program, I began with a literature review. And so what that looked like is compiling all of the resources that were available on migrant farm workers and mental health services among that population. And what we found was that there was little to no research done on this population. There was some research available, and a lot of it was focused here in North Carolina on the farm worker population. So we were looking at the different studies that were done, and that showed us that there was a preference for providing services in the native language, whether that be Spanish-speaking population, indigenous populations, Haitian populations. The cultural efficacy of providing therapy services is best practice to provide in the native language. Obviously, we don't have therapists in Western North Carolina that speak indigenous languages. And so we will try to connect with something like the Migrant Clinicians Network or another translation service to provide those services to those individuals. We've also found that we want to cater our services with a focus and a cultural lens to understand where people are coming from and how to best meet them where they are. One of the ways we do that is with the MECA, a multidimensional ecological comparative approach. This was developed by Cecilia Falikov, and it's integrating cultural awareness throughout the treatment process. So teaching our outreach workers how to engage individuals and teaching our medical providers how to provide cultural relevant services, and including mental health and therapy. It's just kind of throughout that process, we really try to incorporate different perspectives that focus on the patient and where they're coming from. Some other things that we learned is that women felt more comfortable with individual therapy rather than any other kind. Group therapy was one of the less comfortable aspects that individuals endorsed wanting to participate in. We found that cognitive behavioral therapy is the most comfortable and most common practice used for therapy in the Latinx population. And we also learned that the PCP or primary care provider was the preferred place to receive services, and also where they were learning to that they might need those services, where their references were coming from. So looking at some of our cultural expectations, this is an opportunity that I would like to try to engage the audience, either in the chat box or if you feel comfortable unmuting yourself. What does mental health look like in the Latinx culture? Whether we're talking about people coming from Mexico, Nicaragua, Honduras, El Salvador, there's obviously some minute differences within each of those countries. But when we think about it, what do people think in the Latino culture about mental health?
Hello, can you hear me?
Yes, I can.
My name is Jose Santiago Velez. I work at CDC, and thank you for the work you're doing. When I think about mental health issues among Hispanic Latinos, I think about the social determinants that they have to confront, and the particular social determinants which may be different from those of the general population. And risk factors that put them into situations of stress, being in the daily living or as a result of the migrant experience, and also because of the nature of their jobs.
Sure. Thank you, Jose. That's very relevant, looking at the social determinants. Another piece I want you all to think about is getting a Latino male through the door to accept and receive mental health services. What does that process look like? I see a comment from Hans Lolibara saying machismo. So there's this attitude of machismo, like I can do it myself. No soy loco. No, I'm not crazy. I don't have these problems. Other times they pursue the aspect of familismo, or relying on your family to help resolve these issues. Oftentimes, the Latinx population will defer to the church or religious practices to try to resolve some of their issues. And I also want to identify, as a white male working in this population, I don't expect to know what their experience was like. And so I really want to empower my clients and individuals to assess their own experience and tell me what they're experiencing and what their culture tells them about their mental health. But these are some of the things that we've learned from the greater studies and overall research that we've done. And in my experience of working with these individuals, is that they shy away from those services. In the clinic, we see a presentation of somatization, so experiencing pain, headaches, stomach aches, sleepiness, instead of I feel depressed, I feel withdrawn, I can't connect to my family. And in the farm worker populations with an H-2A visa, oftentimes these individuals are moving away from their families. They're learning to do things on their own for the first time, or just having a very distant approach from their common supports. And so that can be very difficult and isolating for an individual. So these are all things we need to consider when approaching the farm worker population and the Latinx population around mental health services, which led us to a lot of mental health education. Before we kind of roll into our mental health education, I want to take a moment to address what happens during COVID. And COVID was a learning experience for all of us, right? So things really changed during March of 2020, and we all had to kind of shift gears to address that. So what were some of these changes that we had to experience? Well, first of all, we weren't going to the same office anymore. We were having meetings over Zoom to discuss how to best provide services to our farm worker population. We never fully shut down during COVID. We continued to do the work that we were doing, but a lot of it was through telehealth. A lot of it was through these Zoom meetings with our staff and the North Carolina Farm Worker program and the North Carolina state was providing a lot of resources and education around how to best address this issue. And so we had to spend a lot of time to learn how to best resolve these issues and best practices in order to continue to provide those services, as I'm sure all of you have had to do. This forced us to learn about telehealth, to provide those services over the phone and through video if we could. One of the deficits that we noticed is that in Western North Carolina, there's a pretty big lack of internet out here. and not just internet. There's a lot of farms and locations where they don't get very good cell phone reception. And so without cell phone reception, like those individuals are going without care for quite some time. And so we partnered with a lot of other local organizations to make sure we were trying to reach out to those areas and make sure that our farm workers felt supported, had education and information around what is COVID, how to protect yourself, how to proceed if you think you have COVID or any symptoms, what to look for in other people and individuals. This led us to bringing on a team that addressed specific COVID issues in July. And at the end of the summer, we actually were able to utilize our new mobile unit to go out and provide testing to individuals and really engaging people more fully in COVID awareness and COVID procedures. We've also partnered with the local health department to provide vaccinations. We're not necessarily providing the vaccinations, but connecting them to services so that they have those available to them. So rolling into the mental health program establishment, for those of you that are thinking about beginning a program or already have a program, what does that look like? Where do you start? Those are a lot of the questions that we were trying to answer back at the end of 2018 when I came on board and just graduated from Western Carolina University. So we start with our background. Is there a need in your community? What are the needs of the patients? Are you seeing a rise in mental health needs? And I suspect after COVID times, we will see a rise in anxiety. I've learned from the American Psychological Association that depressive symptoms and anxious symptoms are on the rise throughout the United States. And I do not think that the Latinx farm worker population will shy away from that. It might take more time for us to learn about that or to study that, because based on the literature review, the lack of information that is out there, it tells us that it's going to be a while before these issues are looked at. So our outreach team had been working with the farm worker population for 2 years, since like 2016, and trying to help them connect to local community health centers to provide therapy services to those that needed it. And what that looked like is going out and getting individuals from their home, providing transportation to the community health center, providing translation services, because oftentimes our community health centers did not have those services available to them. And one of the reasons we were able to do this and start this was our community connections. So as I mentioned, I went to Western Carolina University, and Vecinos was based out of Western Carolina University. And my wife was actually working in a PT clinic that was a free pro bono clinic run by students that provided PT services to the local population. And so Vecinos was able to partner with that clinic, where Marianne, the executive director of Vecinos, met my wife, who then introduced me to start doing some translation and going on outreach efforts. And so we made this connection and realization that there was this need for mental health services, and I could be one of those mental health providers, since I was able to speak Spanish and provide those services in Spanish. And it's just really amazing to utilize those connections and community resources, right? Vecinos then went through an internal clinical review for capacity to assure that we were able to house behavioral integrated healthcare, that we were able to provide those services to our clients. We made this possible through other grants, such as the Office of Rural Health. And then we had to look at our policies and procedures to make sure that we were able to provide clinical services to farm workers throughout their stay. And one of the things that we've run into is farm workers are often here for such a short period of time, and providing therapy services, especially for something like trauma or depression, can be a long-term treatment process. And we don't want to dig too deeply into that if we're going to lose touch with our farm worker or our individual within a month, within the next 2 months. And so we also started to begin providing mental health education. Beginning this program, and as we started doing this work, I found it important to do a questionnaire or a community mental health needs assessment to ask the people what their needs were, what services they would pursue, because it's best practice to use what the people want and need and say that they need. And then we began implementing those services that they were requesting in clinic at outreach whenever we could. And we're moving towards making services more available in the outreach setting. Obviously, during COVID, we scaled things back quite a bit, and I didn't take on as many new clients during that time. But we were still able to provide the therapeutic distraction techniques, which I'll show you here in a minute, and some other mental health education pieces to keep people engaged and thinking positively.
Kenny, there's a question regarding how the amount of staff that you need to give that kind of service.
That's a great question. And it really depends on what your capacity is and who you're trying to work with. And so, as I mentioned, we have 6 staff, full-time staff on staff with Vecinos. And when I started, that number was only 4. We had 4 full-time staff members, not including myself, because I'm only part-time at Vecinos right now. And so really, it doesn't take a whole lot to start this program. If you have outreach workers doing this work and collaborations with a psychologist, a psychiatric nurse practitioner, a licensed clinical social worker, an MSW program, a counseling program from a university, you just need some oversight to provide education around those services. It says, how many of the 6 staff are providing mental health services? So really, it's myself, and I have 1 or 2 interns per year. And then when I don't have the interns available, we have provided some education for our outreach team to provide mental health education. So as they go out and we're talking about diabetes management and high blood pressure and just overall well-being, they drop those hints of the mental health piece. And then as farm workers come back to ask more about that, that's how we get our referral process coming in. Does that answer those questions?
Yeah, there's another question regarding if the needs assessment report is available, and if you publish kind of like your information regarding lit review and gaps, kind of like your findings on gaps for this population.
Yeah, the literature review is just in-house. And so I have a copy of kind of like all of the literature that's out there that I would be happy to forward to anybody that emails me. I don't think everybody needs that. It's a lot of information that's in there. But I'd be happy to connect with anybody. And my email will be at the end of this presentation. As for the needs assessment, I'm also going to get to that later in the presentation. You'll see our results from the first needs assessment, and then I'm going to show you our updated needs assessment as well. Is that all for now?
Yes.
Excellent. Thank you all. Please keep the questions coming. I love to make this as interactive as possible. So looking at beginning our mental behavioral health integrated health program, we developed and built an advisory board with our executive director, Marianne Martinez, myself as the lead therapist. We have a psychologist at Western Carolina University by the name of David McCord, who's been very helpful in bringing in fresh minds and ideas to help support this population in the clinic and during outreach. We have community partners at different agencies that are also doing mental health work. And then we regularly have interns that kind of change over. When I began doing this work, I had a licensed clinical social work associate. So for our first 2 years of licensure, we need to have a supervisor. And my supervisor joined our advisory board as well, which has been super helpful. And we meet probably quarterly at this point to discuss any changes or development in our mental health program. So what does your program framework look like? What do you need in order to start an integrated healthcare facility? You want to follow an integrated healthcare model, right? So that's an interaction and collaboration between typically what they're thinking is your nurse, your doctor, your social worker, or counselor that's on staff. But I also want to add the patient into that mix. The patient is at the center of everything that we do. And we should be basing all of our services around what the needs of the patients are. And then in the farm worker health program, we also need to consider the community health worker. They're essential in creating those relationships and connections and being able to connect the farm worker to these provider and these staff. I talk a lot about the warm handoff. So the community health worker is essential in developing that relationship with the individual and then helping connect them to services and giving this warm handoff, a pass off to the provider, the care that they need. We want to consider migrant farm workers and as I was mentioning earlier, the short period of time that they have with us. And so what type of services can we provide? Is it best to provide education? Do we want to try to engage them in actual therapy? And it all depends on how often we're able to access that individual and how long they'll be there. But we want to make sure we're not delving into like a therapeutic process that we can't terminate effectively to leave that individual better off than when they started. Seasonal farm workers are farm workers that are around for a certain amount of time or like in the area. And so we continue to work with them in our clinic setting or, wherever else we need to meet them. And that can kind of create a more long-term therapeutic relationship. And then this education piece is what we found to be essential in providing and beginning mental health services. You can't convince an individual to accept and utilize services that they don't understand. Or, if an individual is still not fully aware that they have an issue with drinking or full-fledged depression, then they need to understand that further before they're able to accept help or ask for help and engage in the treatment process. So what does our mental health program look like? Salud Mental. Our community health workers register new patients every season. So at the beginning of every season, we have 1 to 3 visits with a site or a farm and get all of the new patients and any patients that are needing follow-up care registered to be seen. In this registration process, our community health workers are completing the PHQ-2 and PHQ-9 if needed. I'll go into that in a second, a little bit more about that. The RHS-15, the rural health screening, and then the CAGE aid, which is a substance use questionnaire. And as needed, we will incorporate this multidimensional behavioral health screening, which is a tool based on the MMPI that I'll show you an example of later in the presentation. And then if an individual is in need of mental health services, I or another therapist will need to complete a biopsychosocial clinical assessment. And this is where we incorporate the MECA, the multidimensional ecological framework, to best assess the cultural needs of an individual and where they're coming from. And then our community health worker will make that referral to mental health services or dental services or medical services, whatever the individual is presenting that they need. So when we first started this program, I was operating in the medical offices that look like this picture on the left-hand side. I hope you're seeing the left for this one. And that felt like a very sterile environment where a patient comes in with presenting concerns and the medical provider tells them what's wrong and they take this medication and that's going to fix it. Well, folks, that's not how therapy works. And so we wanted to create a more welcoming and open space where it could be a collaborative process between the therapist and the patient. And I tell my patients, I'm not here to solve your problems for you. We're going to solve them together. I wanted to show off our new mobile clinic as well. So on the right-hand side is where I would be doing therapy in this smaller space behind the driver's seat. And there's a door that would shut us in. On the left-hand side is kind of you're walking into the clinic and we have our open space, and the far left of that image or the far back side of that image is the provider room. And one of the pieces that this new clinic has enabled us to do is provide more privacy and security. When I first started going out in the fields, I would take individuals and go find a log to sit on or, a shaded spot or some chairs off to the corner away from everybody else. But with time, they understand who the medical provider is, who the therapist is. And, we don't want our clients being judged for seeking therapy services. And in this new mobile unit, it allows us to provide that privacy and security so that when they go in, they register and nobody else knows who they're seeing or what need they're seeking. Some of the things that we've learned throughout this process is that it's important to maintain communication, right? So I don't see things the same way as our outreach workers do, or a medical provider would. I have this lens of the social work model. And so it's important to have those conversations. And I've done a lot of trainings with our team around motivational interviewing, like kind of pulling out the goals of the client and making sure that we're continuing to meet the client where they are and work from their perspective instead of telling them, hey, you've got diabetes. You need to eat this, this, and this, not that. An individual is going to listen a lot better when you're approaching it from their goals and their motivators to improve their own care. We go through this process of encounter tracking. During my time here, we have switched from paper records to an electronic health record system. We use AthenaNet, and that has been wonderful in tracking our patient care. And through our granting agency, we're also required to enter that information into phases, which is another tool that we have to count the number of farm workers that we've served per year and the services that are being provided. And so as you continue to do this work, you know how important it is to keep track of your numbers, to report back to your granting agencies or to your funders of the work that's being done. It's also important to track your patient's progress. I mentioned the multidimensional behavioral health screening earlier, the MBHS, and I'll show you an example of this in a moment. But that really allows us to look at how the individual is presenting when they come in, and then we try to administer this at every patient, every visit with a medical provider or licensed clinical social worker. We went through the process of updating our policies and procedures, creating a mental health Salud Mental manual. We needed to update our consent forms because those look different than the medical practice. Oh, I forgot to mention that during COVID and adopting to the telehealth model, there's a whole nother set of paperwork that goes along with that, right? So when an individual comes into the doctor's office, you sign that consent or release for services. That's different for telehealth because it's a whole different set of policies and procedures. And so we had to get our outreach workers back out to all of my clients that I was seeing through telehealth to get them to physically sign a piece of paper, allowing them to participate in telehealth services. And now that's standard practice. When I see a client in clinic, we get them to sign the telehealth and the consent to regular services so that if we do need to switch back to a telehealth visit at any point, we have the release and consent for that. There was also some growing pains in learning the billing codes around behavioral health services. When I started as a community health therapist in the community health center, all of that happens in the electronic health record, just kind of behind the scenes. But at Vecinos, we had to understand the service code, like what we're doing, providing 1 hour, 30 minutes of mental health therapy or telehealth services, and then the diagnostic code. So assigning a diagnosis and the services that the individual is receiving or presenting with. And so those differ and have to be tracked and recorded if you're billing or depending on your granting agency. Okay, so we had some questions. Do we have any other questions so far?
There was a question regarding, as you mentioned, a lot of the services that you do, how many services do you provide at one time?
Well, ideally, you try to provide as many services at one time as you can. But I mentioned our outreach model is 1 to 3 visits. So the first visit is usually just our registration process and understanding what the needs of the farm is. If we don't finish all of that in one visit, we come back and finish it and maybe bring a medical provider or a therapist, depending on the needs of the farm at that time. So you would bring along a community outreach worker, your program manager, or whoever's overseeing the operation, a medical provider, a therapist if needed, or just somebody that's able to provide mental health education if there's not a need for therapy services at the time. And so during those outreach visits, and probably the second or third visit, that's when you'll start doing diabetes education, mental health education, COVID education. We did a lot of that during the hand washing and wash, distance and wear a mask at all times. I think I have an example of one of the sheets that we passed out to show people our acronyms and get them engaged in that process.
There's also the question regarding what are the common billing and DX codes that you use?
So I don't have the numbers memorized, but we typically provide 1 hour of therapy services, 30 minutes of therapy services, and telehealth services. So those would be like the treatment goals or the treatment codes that we're entering. And then the most common diagnoses that we're seeing are trauma or post-traumatic stress disorder, or unspecified or uncommon other specified trauma, depression, major depressive disorder. Before jumping into something like a trauma or depression or generalized anxiety, I'll typically use something like an adjustment disorder. So if I'm seeing a farm worker that's just presenting for the first time, and he says he's like sad and lonely and it's been this way since he moved here, that might not be depression. And so we can use an adjustment disorder to take some time and figure out what's really going on before putting something like major depressive disorder or generalized anxiety on the list. And in order to do that, there's also one other common code is the psychiatric or psychological assessment. So as a therapist, I need to complete an assessment in the first 1 or 2 visits. So I might have, an interaction where I'm not doing therapy. I'm just kind of explaining the program. But before I can provide a diagnosis, I need to do a biopsychosocial comprehensive clinical assessment. And that's when we'll come up with that diagnosis.
Thank you. That will be all. Yeah.
Thank you. All right. So let's get into the mental health needs assessment, or the questionarios. It's a great place to start getting information from individuals about what their needs are. So, a lot of people know what a needs assessment is, right? So you're looking at your stakeholders, who you're trying to provide services to, and what services are needed. So you gather your stakeholders and figure out who you want to participate in this survey. And we were focused pretty heavily on migrant and seasonal farm workers. So that's who we were trying to gain information from. And when we did this the first time, it was like a 2-page front and back questionnario that was pretty involved. And so what we found was that there were too many questions, and not all of them got answered and filled out on every survey. And then we also started at a time that it wasn't ideal. So we started the assessments in December, but our migrant farm workers we had like Christmas tree workers during December and January, but we really didn't get like a whole lot of our farms back in place until March. So timing is everything as well, making sure that you have your population available to facilitate and participate in those assessments. And so figuring out what's important to these individuals and what services they are likely to pursue is kind of what we're trying to get at. And I'm going to share another screen with you real quickly here to show you the questionarios so this is the updated version of our questionnaire. Can we see that?
Yes.
Okay, great. So it kind of explains briefly in Spanish what they're filling out and why they're filling this out, and letting them know that we're using this to improve our own services. And so I'm not trying to publish this information. I'm going to show you some of the responses here in a second, but it's not going to go into any detail about the individual. Their privacy is protected. You want some basic demographic information. We're figuring out whether or not they're a patient of Vecinos. I want to get a baseline understanding of what they know about Salud Mental, what they know about mental health. What does therapy mean to them? And then kind of looking at symptoms that they might have had over the past 3 months. And it's good to provide different ways to ask these questions. So we're providing multiple choice questions. We're providing some scaling opportunities. We have some fill in the blanks. I find that anything that they can just check off is more likely to be facilitated. Oops. I messed something up there. I'll go back and fix that later. Kind of figuring out what services that they're interested in, and if they would like some more information, they're given the option to provide their contact information, and we can reach out to them. All right, going back to the other presentation. Moving forward. Okay, so let's take a look at what we learned in our first mental health survey or a questionnario. Our demographics, we facilitated this survey with approximately 67 people, I believe. Nope, 47 individuals, sorry. And we had a majority of our individuals between the ages of 18 to 40. And most of our assessments were completed in the clinic, not in the camps. There should be one more slide to show you some of the graphs. Okay, so it's kind of broken down by gender, age, setting. Oh, and that is, so to give you a brief summary of what we learned, in the literature review, if you remember, they had said that individuals preferred individual therapy services over group therapy. But what we found in our local population was that they preferred dynamic activities and individual therapy sessions. They also had mentioned that they didn't know a whole lot about mental health, but there was an interest in receiving more literature around mental health. So we created a mental health modules based on this information. And then there was an interest in dynamic group activities. So we took some of those mental health education modules and started to create like a group Jenga game, the group bingo ideas, and just some activities that can be done on a larger scale with more people than one person at a time. And all this time we're, building in mental health education to that process. One of the things that we learned, and as I showed you in our last, in the example of the questions, is that it wasn't very easily accessible. Our clients weren't accessible. And so when we updated this mental health needs assessment for 2020, we created that online form so that it can be completed with a link to your cell phone. It can be completed by an outreach worker on an iPad or on their cell phone. And we want to be able to make that just more accessible. And what the Google Forms does for myself is that, research and data processing is not my strong suit. And hopefully you may have access to someone that's able to process that information. But what we learned from the first round of handing out those paper copies is it took me time to find a psychology intern or individual that was interested in compiling that information into charts and understandable what we gained from that. And that took like 3-4 months before we really understood the results of our surveys. And so Google does that for you, which I'm going to show you right here. So there's this beautiful, we've had 11 participants in the online survey so far this since it was built in 2020, which means we have not done enough outreach and actually pushing the survey out there. But it breaks down the sex of the individuals that are taking the survey, the age. And so the, are you a patient of Vecinos wasn't answered. And then it kind of shows, this is like that fill in the blank spot. So it shows some of the things that they're interested in and what they know about mental health. It shows what therapy means to them. So these are individual responses. So this is more of that qualitative information that we'll have to process. And then our quantitative information is like graphed out for us, which is pretty great. And I do not work for Google. I don't get any money from Google for this, promoting this information, but it's a free way to build a survey that we have found to be super helpful for us. Go back to the PowerPoint presentation. And we also learned, so as you can see with the 11 participants so far in this current survey and the 46 from the past survey, we want to get more participation and information, which might mean I need to find some grant funding in order to pay individuals to take the survey, or find gift cards, or collaborate with a local tienda store that we can get the individuals to get something out of taking that survey, and make ourselves more accessible and open to administering the survey, which I'm trying to get some of my interns to work on as well. So that leads us to mental health education and just kind of building a system that breaks down the stigma of mental health. In order to get clients in the door, we need to be teaching them about mental health. here's a small example of one of our mental health educations that we developed during COVID. It was COVID Vecinos. So it's this acronym for how to take care of yourself during COVID times. So we have a set of modules that cover depression, anxiety, separation from your family, alcohol misuse, dealing with children, because oftentimes we have these farm workers that come here, their kids are back at home, wives dealing with all of these issues that kids are having, and they want to better prepare themselves and educate themselves on how to best help their kids that might be experiencing certain things. One of the things that we learned, we started by grabbing some of that information from like JourneyWorks or Vistaprints or SAMHSA, and we learned that it's not necessarily written in an accessible language. And so one of the tasks that we had to take on was making these pamphlets and handouts more accessible, because oftentimes Spanish is the second language for these individuals, and that's what we're presenting information in. And Vistaprints, I believe, actually has, and SAMHSA as well, has handouts in multiple different languages. We're mainly focusing on the Spanish-speaking population at Vecinos, and helping break down some of that language so that it's at a more basic reading level. You want something that's no greater than a fourth grade reading level for like mass distribution.
There's a question regarding if the mental health education modules are available.
Yep, absolutely. I can share those with the presenting agency, or you can also email me and I can share those. Maricel, are you aware if I can upload those to like one person at the NCCHA?
Yeah, you're supposed to be able to upload handouts, so you can add them to them.
Great. I will staff that after this meeting, figure out which handouts I can upload and make accessible for everybody, okay? I'll include that literature review, the mental health education, and probably like a link or printout to our community health needs assessment, community mental health needs assessment. So after you've like really done a lot of this work to prepare your program and make the information accessible and start to distribute that information, we need to track that information, right? So as we noticed, we were looking at some of the qualitative information from the community needs assessment. We also want to track the overall well-being and outcomes of our patients, figuring out how they're presenting. So either if you're using a PHQ-9 to measure for depressive symptoms, you want to administer that on regular frequencies to figure out if you are if the individual is showing improvements over time, if what you're doing is actually working and helping. We've been using the MBHS, which I promised you an example of, and I hope it's coming up here. And if not, I will include that in the handouts as well.
Kenneth, just a quick timekeeping note that we have like around 5 to 6 minutes.
Okay, thank you very much. Let's see what's at the end here. Okay, so let's give you some of the data of what we've tracked so far. So we've had this year 151 mental health encounters. That's between myself and my counterpart, Emily, who's seeing victims of violence, domestic violence specifically, and also just traumatic violence that they've experienced. And we've provided over 585 handouts and mental health education to our farm workers. The most common diagnosis that we're seeing is post-traumatic stress disorder. It's 34% of the individuals that we see. And then our average patient visit is almost 3 visits per patient, but it varies between 1 to 18 visits per patient. And we've had 31 patients receiving consistent mental health counseling through Vecinos over the year of 2020. So what are we taking away from this? We want to focus on making connections, collaborating with outside organizations and grantors, finding people that can help support the work that we're trying to do. The mental health education piece is vital to creating this program. Also putting the client front and center of the work that we're doing. What are their needs? How can we best provide those services for them? And then hopefully having someone within your organization that's able to find the money, whether it's grant funding, private funding, government funding. You want to find some funding to provide for the mental health needs of the population. And then in order to best serve or best utilize that funding, you're going to have to track your patient outcomes. Some of the other things that we've taken away from this is that there are unique factors to consider when creating integrated health for our migrant and seasonal agricultural workers. We've got guidelines for implementing mental health services, starting with assessments and screenings, going into, serving with a qualified professional, such as a licensed clinical social worker or mental health counselor, incorporating the use of your outreach workers to provide education and help connect those services, tracking your performance and the amount of education that has been passed out to the migrant seasonal agricultural worker and what their response is. And then also understanding that during COVID, things, did not always go as planned, but we do the best that we can and shift gears when we can. So I'm going to end here. I'll show you, I can include the PowerPoint slides. They'll have my references. This is a lot of the mental health education and literature that we found. One more slide of that. I'm going to leave you with my contact information and a picture of our team. Do we have any final questions or comments?
Yeah, this is Jose again. Can you hear me?
Yes, go ahead, Jose.
I believe, I'm not sure, but I think you said that the program works with community health workers. I'm not sure if that's what I heard, but if so, how could you get them and what are their roles?
Yeah, so the community health workers, or we call them outreach workers, they are working closely in the clinic. They're the ones that are doing case management, interpretation, transportation, screenings. They're going out and registering clients. They're providing diabetes education. They're providing health education. They're helping individuals understand how to deal with the COVID times. They're the bread and butter of the work that we do.
How about the needs assessment? Would they involve at all in the needs assessment?
I've tried to get them involved in the needs assessment, but it's been hard to, as I mentioned, with the connectivity in Western North Carolina, when they're out there in the fields, we don't necessarily have internet connectivity, and we've switched to that online forum. And so that's part of the reason that we haven't been able to distribute that. And a lot of our focus has been on the COVID response since March of 2020. And so I'm trying to use my Masters of Social Work interns to help implement needs assessments. But yeah, if you have the availability and understanding, that would be a great use of community health worker.
Great, thank you, thank you.
Before we take any more questions, I just want to draw everyone's attention to the chat box when we just posted the evaluation survey for this session. So please take a minute to complete it. We really appreciate your feedback.
And as I mentioned, please feel free to email me any follow-up questions or concerns. I'd be happy to talk about anything that was mentioned today or any other things that your organization is encountering.
Thank you very much, Kenneth. We'll just wait in case anybody else wants to add something in the chat box. And thank you, everybody, for joining in.
Yeah, thank you for your time and your participation. I really appreciate you being here, and I look forward to the work that we're able to continue to do together.
Hi, Kenneth. Thanks for, can you hear me?
Yeah.
Okay, thank you for presenting on this. This is super interesting. I'm working in Kansas City, Missouri. And so there's like a small farm worker population that's about an hour east of here. And we are like in a small nonprofit setting, but we work closely with an FQHC clinic system. So I was just curious, like, are you guys open to, like having visitors if people wanted to like kind of see how your program runs or anything like that? Just to kind of like expand ideas. Are you all going to be doing things like out in the field, in the coming spring and summer? Like if anyone one connected to our program happened to be out there, could we stop by and say hello?
We will be really busy this summer with the farm worker population. And before I say, I would love to have that and like expose individuals to the work that we do. I would have to go through our executive director, Marianne, to make sure that that's possible. But if you want to email me or Marianne, her contact information is on there as well. Her email is not correct. It should be vecinosinc.org.
Okay, thank you so much.
Yep, absolutely.